Hello, my name is Kulasekararaj. I'm a consultant hematologist and honorary senior lecturer at King's College Hospital and King's College London. It gives me a great pleasure and honor to give you a presentation on this session on transplantation in benign hematology. My focus of the talk would be transplantation in bone marrow failure syndrome, predominantly on immune-mediated bone marrow failure, but I'll touch upon some of the data on inherited bone marrow failure syndromes. So just as a backdrop, we know that aplastic anemia is an autoimmune disease where the immune dysregulation is against the hematopoietic stem cell, and the attack depletes the stem cell pool, leading on to marrow aplasia, which leads on to pancytopenia. So it is also important that aplastic anemia should be evaluated very clearly in a patient because it is still an extremely rare disease with an incidence of 2 per million. It is also a diagnosis of exclusion. It can masquerade diseases like hypoplastic MDS and clonal diseases. And also about 10 to 20% of patients with aplastic anemia, irrespective of the age of presentation, could have an underlying constitutional bone marrow failure or inherited predisposition to bone marrow failure. And some of the classical features which needs to be ascertained in the history and in direct questioning and examination are illustrated in this slide. Because we know that there is a growing repertoire of conditions which are associated with familial aplastic anemia and myelodysplastic syndrome, not just the classical Fanconi's and telomeropathies and Diamond-Blackfan anemia, but also newly described constitutional bone marrow failure syndromes, which can present with a clinical phenotype or without a clinical phenotype. So that is very important to rule out a presence of an inherited constitutional or constitutional bone marrow failure. And we know that we've not reached an end to this because newer syndromes are described every year. And still around 40% of patients with the evidence of a genetic bone marrow failure do have an undiagnosed genetic defect. And some of the simple tools like presence of a PNH clone or a 6p copy neutral loss of heterozygosity and clonal TCR rearrangements can be used as a predictive factor with a good specificity and a positive predictive value. So, i.e., if you find a patient with pancytopenia and a bone marrow failure or a hypoplastic marrow, if you do find either a PNH clone or an acquired 6p loss of heterozygosity by SNP karyotyping, you could be reasonably confident to say that this patient has got acquired bone marrow failure. So now you've got a patient with bone marrow failure, be it inherited or acquired bone marrow failure. What are the treatment options? So in cases of acquired or immune-mediated aplastic anemia, the balance is always between immunosuppressive therapy versus hematopoietic stem cell transplantation. So where does the early data come from? And this is looking at the data nearly 15 years back, looking at the outcomes of aplastic anemia, either given first-line immunosuppressive therapy, graph A, or given first-line transplantation or upfront sibling allogenic transplantation through the EBMT registry. And as you could see, although the lines seem to be overlapping, there is a statistically significant difference between upfront immunosuppressive therapy versus bone marrow transplant in patients with aplastic anemia who have a sibling donor, with a better outcomes in the context of bone marrow transplantation than immunosuppressive therapy. And that is one of the reasons that age of a patient who's presenting with the bone marrow failure do come into equation when you're trying to delineate what treatments they should go into. If a patient is less than 40 and has got a HLA identical sibling donor, most of these patients should proceed directly to a HLA matched sibling allogenic transplantation. If they do not have a sibling donor, then they go into immunosuppressive therapy with OsA-TG and cyclosporin. Or if they're over the age of 40, irrespective of the presence of a sibling donor or not, they go to receive OsA-TG and cyclosporin. But is immunosuppressive therapy the right thing? Because we know that there are a number of different events after first-line immunosuppressive therapy. Nearly about a third of patients do not respond. Even in patients who do show a response, CR rates were only seen in up to 15 to 20% of patients. Quite a lot of patients are cyclosporin dependent, quite expectedly at an early stage, but even beyond 15 years, 15% of patients are cyclosporin dependent. And infections and cardiac complications, predominantly in the elderly with fluid overload, dysarrhythmias, are quite common in this setting as well. And if you just look at this one data published from EBMT by Andrea Tichelli and the group, this was a EBMT phase 3 study of an ATG cyclosporin plus or minus GCSF in a large number of patients, which was published in Blood in 2011, 192 patients. So what Andrea Tichelli and the group did was followed up this group of patients. The initial data did not show a difference between with or without GCSF. But when he analyzed the data by overall survival at 15 years based upon the age group, you can see that in patients over the age of 60, that 15-year overall survival was only around 32%. And even in people the age of 40 to 60, it was around 55%. And if you look at the event-free survival, it was quite dismal that only about 25% of patients did not have an event. And these events could be numbers, including death, non-response, relapse, MDS-AML, solid tumors, subsequent transplant, and clinical PNH as well. And we all know that there are a number of other events following immunosuppressive therapy, which one needs to be extremely careful about. Not only is the relapse, but also other clonal events like PNH, cytogenetic abnormalities, somatic mutations, and also solid cancers. So with this backdrop, I think transplantation is attractive in aplastic anemia. And the first point is true for quite a lot of diseases because everybody has a donor. And with the talk of haploidentical transplantation, you will realize that every patient has got a potential donor, but obviously timing and economic reasons are also needed to be taken into perspective. But aplastic anemia is a disease which is not malignant disease. It's an immune dysfunction and an autoimmune disease. So we do not need a graft versus leukemia effect. Hence, GVHD should be avoided at every cost. But it's also important that graft failures are improved in the setting. And we did touch upon the limitations of immunosuppressive therapy in the earlier slides. So what's the data for HLA identical sibling transplantation in aplastic anemia? So we know that cyclophosphamide has been the backbone of the conditioning regimen, and the differences with addition of serotherapy, i.e. ATG in the conditioning, did remarkably improve the overall survival for patients with sibling allogenic transplantation. And this was the data published nearly 10 years back. Even in patients over the age of 30, you could see that there is an potential and a significant improvement in survival on addition of fludarabine and also reducing the dose of cyclophosphamide to 300 milligram per meter square given for 4 days along with ATG, or the so-called FCA-ATG regimen. But if you look at matched sibling versus unrelated donor transplantation using an ATG-based conditioning regimen, This was again a very large series of 1,500 patients stratified into 3 risk groups, i.e. low, intermediate, or high risk, based upon these 5 factors, whether you're over the age of 20 or not, time from diagnosis to transplant of 6 months, CMV serostatus, ATG and conditioning, and bone marrow stem cells. And if you look at it, the overall cohort, these are the differences with statistically significant difference between low, intermediate, and high risk. But if you look at the sibling versus unrelated donor transplant, there is a difference which is statistically significant in low risk, but not in the intermediate and high risk, indicating that if you have these risk factors, irrespective of sibling or an unrelated donor transplant, your outcome or survival is impaired when you have these risk factors added up. But it is not bad with a 60, 70, 80% survival from high, intermediate, and low risk respectively. But unfortunately, the GVHD remains still an issue, with close to 25 to 30% of patients getting acute grade 2 to 4 or chronic GVHD in the unrelated donor setting. So we talked about GVHD is a thing we have to avoid in the context of aplastic anemia transplants because it's not necessitated, because we do not need a GVL effect. So that is why this is critically important. The other issue which we will touch upon is graft failure in aplastic anemia. And we all know that there is 2 primary and secondary, and the risk factors are as illustrated: low stem cell dose, multiple transfusion, allosensitization, progressively falling myeloid chimerism, low immunosuppressive drug levels, or premature stopping of cyclosporin, treatment of CMV, and also the CMV infection and EBV, which needs necessitating reduction of the cyclosporin dose. Hence, I just want to take you through the next 5 to 10 minutes on the developments of a King's FCC regimen of using fludarabine, 30 milligram per meter square per day for 4 days, cyclophosphamide, 300 milligram per meter square for 4 days, and Campeth or alemtuzumab, 0.2 milligram per kilogram for 5 days, using peripheral blood stem cells as the source of the stem cells, and post-transplant immunosuppression being cyclosporin, no methotrexate, no irradiation other than a low 2-grade TBI for patients with 9 out of 10 unrelated donor, and the need to keep cyclosporin trough levels very high and to keep it for 9 months and then a slow taper over a period of 3 to 6 months. And if renal dysfunction is a problem, we tend to use half-dose cyclosporin and MMF. And the initial data, as you're aware, was published nearly 10 years back on a small cohort of patients. And interestingly, to show this significant tolerance of, i.e. the CD3 chimerism, the lymphoid chimerism, never achieving 100% levels, even out to 3 years or 5 years down the line. And subsequently, we were able to show that this is due to the persistence of recipient CD8 positive T cell subsets rather than due to any other specific subsets. And they were predominantly effector or memory T cells. And that gives rise to a tolerance with CD3 chimerism never achieving 100%, i.e. the fractionated lymphoid chimerism never achieving 100%, indicating that there is a persistence of this recipient CD8 positive T cells. And when we tried to get an update of the FCC regimen, both in the matched sibling and unrelated donor, the long-term overall, i.e. the 5-year overall survival was pretty good at 85 to 90%, depending upon volunteer unrelated donor versus matched sibling. So, and this has been taken up by a number of other countries with the data published from Toronto, which is independent to the UK series, and an EBMT retrospective review as well, with low GVHD risk, both acute and chronic, with graft failure rates between 10 to 15%. Still, a median age is not that high, but with an overall survival of around 80%. So with that background, I just wanted to take you through this case. This was a girl who presented to us now nearly 3-4 years with a post-hepatitis AA. She was very unwell with recurrent fevers and admissions to hospital with neutropenic sepsis. She did not have any family history, but sibling was not a match, but a haploidentical. but she did have a 10 out of 10 HLA matched donor identified. And this was her picture when she was unwell in intensive care, intubated. This is presented with her permission. So what would you do for this? So this is an young girl who's previously fit and well, extremely unwell, intubated, new post-hepatitis AA. Would you treat the infection? No matched sibling donors, so would you give ATG? Do you treat the infection, allow her to recover? Would you proceed for a haploidentical, or would you go for a 10 out of 10? And this is based upon the algorithm because she belongs to this category of less than 40, but she does not have an identical sibling donor. So you cannot do a sibling matched transplant. But would you go for a HOS ATG cyclosporin because of that? Or as we did, we proceeded with an unrelated FCC transplantation. And this is her 6 weeks post-transplantation with no GVHD, no CMV reactivation. She did have some subtle cytopenias which resolved, but needed EPO and GCSF when required. And she's doing extremely well many, many years post-transplantation. So the question is, despite her age, and despite her absence of a HLA identical sibling donor, normally she would have gone into this process of having HOS ATG, and if she failed, she would have gone for an unrelated donor transplant. But is there rationale for some people less than 50, if they have a good performance status and a sibling donor, to go for an upfront sibling donor? Or in patients, children and teenagers, young adults, if they have an unrelated donor and if you're able to do a transplantation quickly, like in our case, would you go for an unrelated donor transplantation? And this has been multiply discussed in a number of friends as well, including from the US perspective and from UK and the EBMT perspective. And we've just put together this data of upfront mud transplants in aplastic anemia, and it's just been accepted for publication in American Journal of Hematology. So there is an option for doing in young fit people if you are able to identify donors at an earlier time point and do a reasonably quick allogenic transplantation, or you're able to do that. The second spectrum of patients is older people. So here again is a very previously fit lady with a good performance status with Karnofsky of 90%, good heart ejection functions, renal functions, but has failed to respond to cyclosporin and L-Trombopac. What would you do for this kind of patient? She does not have a sibling match, but because of her general performance status, we proceeded to do an unrelated donor transplant despite her age of 71. She did extremely well, but unfortunately developed graft failure 6 months due to inadequate cyclosporin dependence dosing, and she developed other significant coexisting problems, including abnormal liver functions, patchy shadows in the CT of the chest. What do you do next? We did proceed to a second allogenic transplant from the same donor. Patient is now 72. She's extremely well with good graft function. She's on a combined of MMF and cyclosporin, and she's off immunosuppression as we speak, and she's having a very good quality of life. And this is the spectrum of her neutrophils during her aplastic anemia. As you could see, for 1.5 years, we did the transplant. She engrafted. She did well for 6 months, lost her graft, secondary graft failure. Second transplant is doing extremely well for the last two years. So what's the data for allogenic transplantation in older individuals over the age of 50? So this is the EBMT CA-BMTR data published in BBMT, and looking at a large number of 500 patients with a median age of 58, and looks like that higher mortality was predominantly related to a poor performance status and matched unrelated donor transplant, with age not having an impact on survival, but having an impact on GVHD. And this data was recapitulated in other publications as well over the last few years. But interesting to note that in patients who had CNI plus MMF, CNI plus methotrexate and others, the others which had the lowest acute GVHD and chronic GVHD was the one which had Campath-based or alantusmab-based conditioning. So we went on to look at our cohort of older patients, i.e. more than 50 versus less than 50 age group of patients from diagnosis to transplant and everything. They were all similar. Most of our patients got peripheral blood stem cells, all of the older group, while only 81% got the peripheral blood stem cells in there. Essentially to show there was no difference in the older group and the younger group between engraftment and also graft failure, which was, as I indicated above, was extremely low at around 3 to 5%, and still the chimerism with mixed T-cell chimerism. And the graft-versus-host disease was also only mild, with acute GvHD in 1, chronic GvHD in 7. All cases were confined to skin and were mild. And GRFS, or GvHD-free relapse-free survival, based on age and comorbidities, you can look at it, the HCT-CI had an impact on the GvHD-free relapse-free survival, but not the age, not the age, either less than 50 or the more than 50 had an impact on the GFRS. So, and CMV reactivation was seen, but not CMV disease, as was EBV reactivation. But younger people had a more EBV PTLD, but not statistically significant. And these were the transplant-related mortality. 4 patients died in the older age group, predominantly due to invasive fungal disease and multi-organ failure during the initial period, other than these 2 patients who died for more than 1 year post-transplantation. And this is to summarize this data. So what we think is that there are similar outcomes in the less than 50s and over age. Comorbidities do matter. Low rates of GvHD is seen using HLA-matched sibling and matched unrelated. Incidence of viral reactivation is not increased, but reactivation can be a problem. Stem cell, peripheral blood stem cell can be safely used in the setting of camphor. Late graft rejection do happen. So this is sort of a schematic of the HCT using alemtuzumab, with various advantages and disadvantages as we used, with avoidance of methotrexate, avoidance of TBI, other than in the 9 out of 10 setting, low or absent GvHD, and the long-term cure for aplastic anemia. And we all know how the journey of the sibling transplants have gone for HCT, for aplastic anemia, right from the days of just single-agent cyclosporin, with the addition of ATG, and also addition of flu in the setting of people over the age of 30 or 40, with different outcomes being improved over a period of time, and the publications related to that. And similarly with unrelated donor transplantation as well, with outcomes improving with the addition of fludarabine, and also with the FCC regimen, which I indicated above. Just the last few slides on, can this regimen be used in the setting of inherited bone marrow failure? So this is just one example of the data which was published a few months back, looking at this cohort of Fanconi anemia patients, which were 82, with a median age of 8.7. And if you look at it, the 5-year overall survival was 85.44% in matched related donor transplant, and 95% in matched unrelated donor transplantation as well. And again, indicating that use of alemtuzumab, i.e. indicated in the dotted lines here, had a better overall survival and a GvHD-free, event-free survival as well. And patients with flu-cy regimens having a better outcomes as well. So just to give a flavor that this regimen can be used also in the setting of inherited bone marrow failures, provided they've not transformed to MDS or AML. So there is an argument to say that is there a head-to-head comparison between a transplantation and also with the triple drug regimen of ATG, cyclosporin, and L-Trombopac, with its own advantages and disadvantages. So this is sort of a complicated algorithm, but just not dissimilar to what I took you through in the earlier slides, and this is based upon the current BCSH guidelines. But can you have a conceptual approach to treatment for aplastic anemia as well? So is it acquired or constitutional? Have you ruled out MDS? If it's constitutional, would you think of a transplantation or a danazole? If it's acquired, rather than age, would you look at comorbidity, disease severities, and donor availability? And would you change your treatment regimens based upon that rather than per se on the age of the patient? So I think with that, I'll stop. I'm happy to participate in the discussion and take questions as it comes along. Many thanks.